Hello and welcome. My name is Lori Green, Program Director at Gulf Coast Ultrasound Institute. I'd like to welcome everyone to tonight's presentation on OB case studies. And with that, I'd like to introduce our speaker, Jane Burns. Jane is a perinatal sonographer from Houston, Texas, and she has over 30 years of experience in the field of obstetrics and gynecologic ultrasound. She is the president of the Midwest Society of Diagnostic Sonographers, and she lectures extensively throughout the United States and internationally on OB and high-risk OB patients. She's been a part of the Gulf Coast Ultrasound faculty for several years now, and we've enjoyed so much working with her, and I'm sure you're going to enjoy her presentation. So welcome.
Good evening. Well, OB cases, we're going to go over a variety of different things. OB cases can be kind of challenging because you're looking at a patient within a patient. So we're not expecting you to know all of the abnormalities that I'm presenting, but just in case you run across it in your lab that you know where else to look, what else should I do? What can I do to help try to find out what this abnormality is? So let's go ahead and get started. So our first patient was a 37-year-old, first pregnancy, negative NIPT. That's non-invasive prenatal testing. That's your free fetal cell DNA testing. That's one of the newer tests that's out. And the patient was referred just for an enlarged heart. So as we're looking at a cross-section of the baby's chest, we can see the spine here. We see the apex of the heart that should be sitting at about a 45-degree angle is pointed over towards the left side. This is the right ventricle. This is the right atrium, the left ventricle, and the left atrium. So one of our first things that we need to try to decide is this a small left side of the heart or is it a big right side? So let's go to the next view. Baby, as we were scanning, had episodes of SVT. We've magnified up a little bit, trying to clean up our image. So again, looking at the apex of the heart, left ventricle, left atrium, right ventricle, and looking at the right atrium. So we can see that the heart is occupying more than a third of the chest. So this is an enlarged heart, and the right atrium is the largest part of the heart that we see. And this is it in real time. So again, looking at the small left ventricle here, left atrium. Now look at the right ventricle and the right atrium. And then with color. So when we have an enlarged right atrium, one of our first things that we should be thinking about is why is that right side so big? So these babies, if they continue on, can end up developing high drops, and anytime they develop high drops, then that is a worse prognosis for those babies. Differential diagnosis for this would be a large right atrium with an ASD, an atrialized right ventricle with Epstein's anomaly, a hypoplastic left atrium, or hypoplastic left heart syndrome. So as we're looking through this, one of your first clues that there's a heart abnormality is not just the size of the heart, but that the apex is off axis. About 40 to 50% of your hearts, when they're off axis, there's going to be something wrong. Now you just have to try to track back and try to figure out what is wrong. So looking at those different real times, Epstein's anomaly was the one that was the best, that fit all of the different criteria. You had the apical displacement of the septal and or the posterior tricuspid leaflets. You have a severely enlarged right atrium. Significant portion of the right ventricle becomes atrialized because the tricuspid leaflets are displaced inferiorly. So now part of what should have been the right ventricle now becomes part of the atrium. And then it's off axis in the fetal chest, severe levocardia, high association with SVTs, and increased risk for the development of high drops and pulmonary hypoplasia. So that was an Epstein's anomaly. Our next patient is a 28-year-old, gravida 2 para 1. She had declined any type of genetic screening, and she was sent in just for her anatomy scan. So this is a transverse cross-section of the baby's chest, looking at the spine, so posterior, anterior. And so this is this view in real time. So as we're looking here, what do we see? See this little anterior defect here? So this is looking at the area of the sternum, and it looks like the heart is pushing right out of the chest. Then magnifying up again. You want to optimize your image. You can see the baby's doing some practice breathing movement. Here are the atria. This is the crux of the heart. And look how those ventricles are squished through this defect, through this anterior chest wall. And then with color. So anytime you're evaluating something with the heart, make sure that you're looking at it in 2D and with color, and then later on you'll put on a Doppler also for color analysis. This is the baby with MRI, looking straight at us. Differentials would be ectopia cordis, pentalogy of Cantrell, body stock anomaly, amniotic band sequence, congenital diaphragmatic hernia, or pulmonary sequestration. So out of all these different things, the two that would be the most likely would be the ectopic cordis, because we have the heart out of the chest, and then pentalogy of Cantrell. But pentalogy of Cantrell usually has multiple other things going on. They have omphalocele, major cardiac defects. There's more abnormalities with the pentalogy. So this baby was indeed lucky that it was just ectopic cordis. There was nothing else going on with this child. So ectopic cordis was this abnormality. The heart's protruding partially or completely out of the chest cavity, and it's caused by a defect or cleft in the sternum, has a high association with pentalogy of Cantrell, and a high incidence of heart defects. About 83% of these babies will have some type of a heart abnormality. And this is that little baby once she was born. This is a picture of the heart. About a third of the ventricles were protruding. And what happens is now the chest, because it hasn't been expanded, the entire heart hasn't been inside, you have to slowly try to expand that chest so that we can try to get the heart back in. And so what they did, there's no sternum at this point in time, so they've just skin covering over it, and then the baby has a shield over the chest to protect the heart. And she just recently did celebrate her first birthday. So we get to see these children. They come back and really keep in touch with the docs. So it's always nice to see them come back. Our third patient was AMA, so advanced maternal age, first pregnancy, and sent for an anatomy study. This is a sagittal view of the baby, looking at the top of the head to the back of the head, following the spine down to the area of the pelvis and the anterior abdominal wall. So you can see this is only 19 weeks, 4 days. So we see this extra fluid in here, so there's fetal ascites. And then look at the echogenicity from the chest to the liver to the bowel. What do you think about that echogenicity? A little brighter than we usually see. It's on a transverse. So this is posterior, this is anterior, this is left, this is right. When we talk about cardiac axis, should be at 45-degree angles, plus or minus 20 degrees either way. Where's the apex of that heart? Pointing straight midline, which is called mesocardia. So now we're seeing bright lungs, we're seeing some abdominal ascites, and we're seeing that the cardiac axis is right at midline. So looking at a coronal view of the chest, look at the diaphragm. What can we say about the diaphragm? Is that the normal way the diaphragm looks? No, it's inverted. So flattened or inverted diaphragm, and then looking here. That's the trachea. You should not be seeing the trachea dilated like that. This was the MRI. So you're following the trach all the way down to the bronchi. Differentials would be bilateral microcystic CPAM, which used to be called the CCAM. Now it's called the congenital pulmonary airway malformation. Bilateral diaphragmatic hernias, pulmonary teratoma, or chaos, which is congenital high airway obstruction sequence. Well, bilateral CAMs, they're very rare, and usually you're not going to see the diaphragm inverted like that. Bilateral diaphragmatic hernias, well, then you're going to see intestine up in the chest, so that's not it. This diaphragm is pushed out and the lungs look enlarged. Pulmonary teratoma is usually in one area of the lung. So that leaves us with chaos. So it's a tracheal or laryngeal obstruction, and it's caused by an atresia, stenosis, or web. They're usually bilateral enlarged echogenic lungs. Heart is displaced to the midline, that's your first clue, and that flattened or inverted diaphragm. It's very common for these babies to have ascites, and polyhydramnios is common, and they have obstructed venous and lymphatic return, and 50% have other abnormalities. So if you see this, you need to start looking at other things. Is there a heart defect? Is there a kidney abnormality? What else is going on? The important thing to remember about the chaos is if we don't diagnose it in utero, these are babies that are going to die because they have no airway. So this is a baby we would do an exit procedure on, where they go ahead and they deliver the baby part of the way, get an airway established, and then deliver the rest of the baby. So the baby's still hooked up to the placenta and the umbilical cord. Mom is still doing the circulation for the baby until the peds can get in there, the neonates can get in there and maintain an airway, get that airway open, and then they deliver the baby. All right, case number 4 is a 31-year-old, gravida 3, para 2, late prenatal care. Showed up at about 28 weeks. This is looking kind of like a sagittal oblique. We can see a little bit of the stomach, the diaphragm. This is in the mid-chest, back up into the neck. And then this is transverse of the chest. And whenever you start seeing numbers, and you know there's more than one, so we're actually counting these little hyperechoic areas that we see within the chest. And this is looking at it in real time. So now we see it's not just in the lung, it's in the heart. So look at that big one. So there are actually 6 of these masses arising from different parts of the heart. Once you see that, we start looking around trying to find out what part of the heart these different areas are at. We try to label them. And then we want to make sure we look at the brain, the liver, the spleen, and the kidneys. Because if you see these little masses in the heart, you can also find them in other places in the baby. So looking at the head and the heart, and then in real time again. Look at the contractility of this left side of the heart. Do you see how it looks like the right side of the heart's doing the majority of the work? Left side's kind of just along for the ride. These masses can be so big that they actually interfere with the outflow, with the blood flow through the heart. And then it's so big, it's distending the heart wherever it's growing, and so it doesn't allow for that nice contractility. And then with color. So decreased flow on that left side. Our differentials would be pericardial teratoma, rhabdomyoma, fibroma, hemangioma, myxoma, or large echogenic foci. Any guesses? Rhabdomyoma. Very good. Rhabdomyomas are the most common fetal cardiac tumor about 90% of the time. If you see a mass within the fetal heart, it's going to be a rhabdomyoma. They're usually well-defined masses. They're hyperechoic, homogeneous, smooth-walled, and they have a high association with tuberous sclerosis. If you see multiple tumors and you look other places and you see other tubers, 100% of the time it's going to be tuberous sclerosis. If you only see a single tumor, there's a 50% chance that the baby has tuberous sclerosis. It's autosomal dominant. 30% of the cases are inherited, and other cases are due to new mutations. The problem with this is for testing, even if we think that it's tuberous sclerosis, there's so many different variants of it, we're only picking up about 50 to 60% of them. Where we say, no, your baby doesn't have it, doesn't mean the baby doesn't have it. We don't have the test for it yet. So even though we can try to test in utero, it's not giving us a very good yield yet. So I think as these tests advance, then we'll get better at confirming whether or not this baby has tuberous sclerosis. Prognosis, if they're multiple, those babies tend to live a couple years to 7 years, I think, at the max. They have multiple things going on, especially when the masses are very big and there's an outflow obstruction. Some of them don't even make it out of pregnancy. If they make it through pregnancy, some of the tumor sizes can regress in early childhood, but some of them have to be resected. All depends upon how much of the cardiac function is impaired and what the outflow obstruction is. The question was if we saw that this patient in the first trimester, would we see these tumors? Usually we wouldn't see them at this time. This is one of those things that as the baby grows, as the heart gets bigger, we can see them from about like 20 weeks on up. So you can have a normal early scan and have this show up later. Okay, so this is case number 5, was an anatomy scan, first pregnancy, no significant family history. So this is cross-section of the spine. Left side is up, right side is down. This is anterior, this is posterior. So this is one of your normal views that you get when you're doing your abdominal circumference. So what kind of catches your eye about this? Look at how this umbilical vein comes in. Should it be going towards the stomach? Go back to your basic landmarks. How should that umbilical vein be coming into the abdomen? Second clue, the gallbladder, which should be over towards the right side, is displaced medially. So usually the gallbladder will lie lateral, over on the right side, lateral to the umbilical vein. Here we've got the umbilical vein coming in, and the gallbladder is displaced medially. Differential, midline mesenteric cyst, persistent right umbilical vein, persistent left umbilical vein, agenesis of the ductus venosus, or umbilical vein varix. So in the beginning, everybody forgets in early embryology there are 2 veins, 2 arteries. Almost always the right umbilical vein becomes atretic, and it's the left umbilical vein that we're actually seeing. Comes in midline, goes over to the left portal vein, so it's coming in and it's tipping over. You see the color going over towards the right side. So if the left umbilical vein is compromised in early embryology, then you end up with a persistent right umbilical vein. So that's what this is persistent right umbilical vein. You got to carefully look at the rest of the fetus. If there's no other abnormalities identified, it's just considered a variant of normal. Some centers will still go ahead and do a follow-up for fetal growth in the 3rd trimester. Make sure that the baby is growing well. Sometimes there can be other vascular abnormalities. So you kind of look, make sure that everything's in the proper position. If the umbilical vein bypasses the liver completely, then there is an increased risk for aneuploidy and other vascular abnormalities. So it's very important that that you're still seeing the umbilical vein coming into the liver. If it's completely bypassing the liver, there's usually going to be other problems. So it's just one of those normal variants, and just when you're taking your abdominal circumference, you should be able to pick this up. You should know that that umbilical vein should be pointing away from the stomach, not going towards the stomach, and the gallbladder should be more lateral. It should not be midline. Okay, another mid-abdominal cyst on an outside study. So looking at a coronal view, we're looking from the right side, part of the liver here, diaphragm, and this hypoechoic structure, and we see some enhancement posteriorly. Put color on, so we see the umbilical vein coming in. It does go over towards the right, away from the stomach, but again, we see this cystic anechoic structure in the middle of the liver. Differential, liver cyst, gallbladder duplication, choledochal cyst, umbilical vein varix, enteric duplication cyst, mesenteric cyst, or ovarian cyst. Gender is very important because if you have an ovarian cyst, and a lot of these don't present until after 25, 26 weeks with ovarian cysts, those cysts get so big that they actually auto-amputate and they can float around in the abdomen, so they can be anywhere in the abdomen. But one of the other things, so I'll tell you this is a male fetus. If it's a male fetus, then what would you think? Choledochal cyst. Congenital dilatation of the extrahepatic and or intrahepatic bile ducts. It's usually saccular or fusiform, common bile duct. Dilatation about 80 to 90% of the cases. Coronal view is the most helpful. So you're going to scan, get in the coronal, looking from side to side on the baby's abdomen, scanning from anterior to posterior. That gives you the most information. If you can obtain a clip, that's the best way to do it. Use color to rule out that it's not any type of a vascular collection, and it's more common in the Asian population. One more abdominal cyst, because you'll get a lot of referrals for abdominal cyst. So mid-abdominal cyst on outside scan, gravida 4, para 3, AMA, advanced maternal age. So now this cystic structure we see is a little bit lower in the abdomen, right above the bladder. Looking at a coronal again, looking at part of the heart, the diaphragm. This is coming right up, the umbilical vein coming up into the liver. Look at this little area here. Remember, if there's measurements on it or if it's labeled or has numbers, it's something we want to look at. Look at the size of this compared to that. It's 12.8 millimeters. And then put color on. Anytime you see any type of a hypoechoic structure, whether it's in the abdomen or the brain or anywhere in the baby, put color on it. Turn your color gains up and see if you get any flow in there. That's going to help you with your differential. So another cross section of the lower abdomen to the pelvis. There's the bladder, umbilical vein coming in, and then this little turbulent area right here. And then with the bladder, again, you can see umbilical arteries here, and this little dilated area here. Differential again, midline mesenteric cyst, persistent right umbilical vein, persistent left umbilical vein, gallbladder duplication, umbilical vein varix, umbilical cord cyst, choledochal cyst, ovarian cyst. You see how there's overlap as you're doing all of this. Well, it could still be a midline mesenteric cyst, but we put color on it and it's got flow in it. So we know right there it's going to be something vascular. It's a little bit low for it to be a persistent right umbilical vein. Gallbladder duplication is not going to have flow in it. Umbilical cord cyst is not going to have flow in it. Choledochal cyst and ovarian cyst are not going to have flow in it. So we've really narrowed down our differential. And most likely is going to be umbilical vein varix. It's a focal dilatation of the umbilical vein greater than 9 millimeters or twice the size of the intrahepatic portion of the umbilical vein. So color is really what's going to help you here. There's usually turbulent flow pattern, increased risk for thrombosis. That's why we watch these. Possible high drops, IUGR, and or intrauterine fetal demise. It's usually intra-abdominal and extrahepatic, so before that umbilical vein gets into the liver. Maybe the first sign of elevated venous pressures, may develop cord compression. An important thing to remember about this too is if you see one of these little varix in the fetus, then look at the other end. Look at the placenta cord insert too, because sometimes you can see them there. And the more of these little dilatations that you see, the greater the risk for some thrombosis and then a vascular event with the baby. And you want to monitor for anemia, so you're going to do a mid-cerebral artery Doppler and check the cord again to make sure that there's no varix along the cord, especially as it gets closer to the placenta. All right, moving on. Still one more abdomen thing. This patient was referred at 17 weeks for anhydramnia, so we could see no measurable fluid outside of the fetus. So this is the spine, this is the pelvis, this is the baby's tummy. Up in here is a little bit of the chest, and way up here is the head, and a little bit of the arm. Looking at that abdomen again, here's the stomach and liver. Look at this, huge. And then looking at the kidneys as we move posteriorly. So we can see that the echo texture of the kidneys is brighter than we usually see. We can see that there's dilatation to the central collecting system, and then we see this huge anechoic cystic structure in the baby's abdomen. It is male. Little boy part sitting right there. One of the things that can happen is you can actually get rupture of a ureter, a hydroureter, or the bladder itself if there's enough pressure in there. But look at this. Now this is looking at the bladder, so we're telling you it's the bladder coming down into the pelvic area. See this? And then in real time. Now look at right here. This is classic for this abnormality. And looking at those kidneys, look at these megaureters. Look at how dilated these ureters are. If normal ureters, you're not going to see. See how tortuous they are? They're just kind of winding back and forth. The other thing you notice too is, okay, so the abdomen is distended because of this enlarged bladder and the kidneys and the ureters. Look how compressed this chest is. So babies with kidney abnormalities, bilateral kidney abnormalities, they don't die from the kidney abnormality, they die from pulmonary hypoplasia because there's not enough fluid in there to allow those lungs to expand and grow and develop normally. They need to have that fluid, the amniotic fluid. So differential cloacal malformation, prune belly syndrome, megacystic microcolon, urethral atresia, posterior urethral valves. PUV, there you go. This is your typical keyhole sign that you see with PUV. So this huge dilated thing that we see is in all a very distended bladder. And that, along with the male fetus, until proven otherwise, PUV. Okay, so there is a treatment option for this if we can catch them early enough. It's for a lower urinary tract obstruction, so it's called LUDO. You can put an intra-fetal shunt in. They drain the urine from the bladder, then they retap the bladder from the next day and send to the lab to see what the renal function is, what the chem is. Because if there's not enough good renal function left, they're not even going to bother putting a stent in. You can't use the initial urine because it's been sitting in there for so long. So you're actually draining off, sometimes it's 700-800 cc's that you're draining off. And then you have to bring them back the next day, retap them, send that fluid off to the lab, and then they can make an evaluation as to whether or not they'll put a shunt in there. The question was, is if we do this intervention, how is it going to affect pulmonary hypoplasia? Usually by 16 weeks, that's when the kidneys take over the majority of the fluid. That's why before 16 weeks, you can't say that there's normal renal function because there's still normal amniotic fluid until the baby takes over 80% of the urine production, which is at 16 weeks. So 16 weeks, so this one was 17 weeks. So we know if we intervene now, there's a good chance that we can salvage these kidneys. So the kidneys look bright, and part of that is because there's so much dilatation. Anytime you add fluid, then things are going to look more echogenic. So all of this is a drainage problem. So if we can drain that off and get normal fluid around the baby, there is a good chance that the babies will do well. The problem is you put a shunt in, baby pulls it out. Or you put the shunt in and it goes up into the abdomen. So there's all these different things. So it all depends upon how long can you get normal fluid around the baby, which pushes the uterus away from the chest, allows the lungs to expand. Sometimes we're very successful, sometimes we're not successful, no matter what we do. Good question. All right, this one is an 18-year-old first pregnancy. Just so happy all she wanted to know was the gender of her baby. No genetic screens, and all they sent in on the referral was abnormal ultrasound. So just looking at the sagittal view, looking at the top of the head, the face, pay attention to these little lines here. And looking at the back of the head, spine, torso, hand, legs, down to the tush. So we've got normal fluid, so we know that at least one kidney is working and that there's a way for that urine to get out. It's looking across the front of the face. This is looking at the chin, the cheeks. Here's an orbit with the lens of the eye. Look here, there's this big cleft here, following it up all the way up through the orbit. And then we see this little attachment. And again in real time, so looking at the front of the face. Hand again. So you can see how that comes in. There's a distortion from the maxilla up through the orbit, through the middle of the head, and then over towards the side. Now looking at a cross section of the head. This is the back of the head. This is cerebellum hanging out back here. So left, right, anterior, posterior. So what can we say about that head, that calvarium? Well, it's not intact. What about the structures of the cerebrum? Well, not much that looks normal, so kind of disorganized. Look at the cord. So there's a marginal cord insert. This is part of the abdomen. What else can we say about that cord? Look how straight that is. Yep, 2-vessel cord. But then look how straight that cord is. There's no coiling. And it's kind of short too, isn't it? And then the 3D, looking at the front of the face. So you've got these clefts extending up into the orbits. Huge midline cleft there. And looking at the back of the head. So here's a little bit of the head. This is all the back of the head. So differential limb-body wall complex, amniotic band sequence, pentalogy of Cantrell, ruptured omphalocele, and gastroschisis. Well, ruptured omphalocele usually is not going to have extension up into the face. And then you also have this encephalocele that we're seeing at the back of the head. Gastroschisis has a very low association with other abnormalities and chromosome abnormalities. Very low. Pentalogy of Cantrell usually is going to be more ventral. It's not going to involve the hands and the back of the head. So that kind of leaves these two. So what do you think? It is a limb-body wall. You are correct. Because of the short cord, it's so close. Sometimes these babies are actually even just attached right to the placenta. The cord is so short. They're just attached. And then they have this bad scoliosis because everything is pulled forward, attached to the placenta, so they can't move. They're growing, and they can't move away from the placenta. So a limb-body wall complex has a lot of amniotic bands, and they have that hallmark of 40% of them are going to have craniofacial defects. And you can see these bands going everywhere, but because of everything else and the distortion of the abdomen, it's not just amniotic band. This is actually a limb-body wall complex. It's also known as a body stock anomaly. It's lethal. You have attachments of the visceral organs to the placenta with a short or absent umbilical cord. You have gross distortion of your anatomic landmarks. You look at the head, you look at the tummy, nothing is making sense. Everything's kind of disorganized. Scoliosis is very common. Limb abnormalities are common. And again, 40% are going to have these craniofacial defects. A lot of what we do is looking at twins, looking at multiple gestations. With IVF, we're having more and more of these multiples, and they bring a very different problem to our lab. So I just wanted to go over some of these twinning problems that we can see. So multiple gestation concerns, this growth restriction is more common in multiples. Discordant growth due to unequal placental sharing is more common. Anomalies are 2 to 3 times more common in twins. Placenta previa and vasa previas are more common. Cord insertion abnormalities into the placenta are more common. There's an increase in maternal complications because of the overdistension of the uterus, preterm labor, and the risks vary with chronicity and amnionicity. So multiple gestational imaging, you want to determine the chorion and the amnion. You have to closely monitor their growth. You look for signs of crowding, such as clubfoot, and careful monitoring of the amniotic fluid. So when we're measuring the amniotic fluid around the baby, in multiples, we're going to use the single deepest vertical pocket, or DVP. You do that measurement perpendicular to the floor, not the maternal abdomen. So that means you have to be scanning in a straight AP. And I know some papers will tell you, or some articles will tell you to do it transversely versus sagittally. It doesn't matter as long as you're AP. I mean, if you're AP, it doesn't matter which way you look at it, it's still an AP pocket. So make sure that you don't measure through the cord or fetal part. Polyhydramnios is greater, deepest vertical pocket greater than 8 centimeters, and oligo is less than a 2 by 2 centimeter pocket. And I say 2 by 2 because you can have a 2 centimeter pocket this way, but only half a centimeter in width. It has to be at least 2 by 2 to qualify it as normal fluid. If it's less than that, even if it's 2 by 1, it's not, it's oligo. If that's all you can see and all the fluid around the baby, that's oligo. It has to be at least 2 by 2. And then amniotic fluid discordance is the most important single predictor of poor outcome in a multiple gestation. So that's why we monitor these babies. Starting from early on, 14 weeks when they're monochorionic, we're going to follow them every 2 weeks, and then every 1 week, and then we follow them throughout the pregnancy. Looking just limited to look at what the fluid is, the stomach, and the bladder. So twin prognosis, again, is related to the chronicity, not the zygosity. So it's really about what is the placenta, what is the blood supply, what does this baby have providing for the nourishment. So move over to dizygotic twins. Dizygotic twins have 2 ova, 2 sperm, 2 zygotes, 2 yolk sacs, 2 placentas, 2 chorions, 2 amnions. Ultrasound findings that we see with dichorionic diamniotic twins, they should see a thick intertwin membrane. You may say 2 separate placentas. They may be close together and it's difficult to see, but what you want to look for is that lambda sign because you have 2 amnions and 2 chorions, so it's thicker. So you're going to have that little lambda sign. It would be nice if everyone was like this, huh? But they don't come like this, not often. So it's called a twin peak sign or the lambda sign, and it's so thick because we have 4 layers rather than 2. So you have a wedge of chorionic tissue extending into the base of the intertwin membrane. And the other way you can tell they're dichorionic diamniotic is if they're different genders. I mean, if they're monochorionic, they're going to be the same gender. So if you're having a hard time looking for the membrane, go look at the genders. If they're one of each, then you know that they're dichorionic. Monozygotic twins, on the other hand, 1 ova, 1 sperm, 1 zygote that cleaves to produce 2 embryos. And then there's different types of monozygotic twins. There's dichorionic, diamniotic. The earlier they split, the less they share. So if they split really early, they don't even share any kind of placenta. If the zygote divides within 3 days post-conception, you have 2 implantations, 2 chorions, 2 amnions. And the ultrasound findings are going to be the same as what you have with the dizygotic twins because they have the 2 placentas. They don't share a circulation. So even though they're monozygotic, they each have their own placentas, so they are very low risk for any problems. They have a thick membrane, 2 yolk sacs, but since they're monozygotic, they're going to be the same gender. So when you have dichorionic twins, 2 placentas, and they're the same gender, 80% of the time they're going to be dizygotic. But 15 to 20% of the time they're monozygotic, they just split early. Does that make sense? Good, because everything else we do is based on this. Okay, monochorionic diamniotic, we have the cleavage occurs before the amnion differentiates, so 4 to 8 days post-conception. You have 1 implantation, 1 shared placenta, 1 chorion, but 2 amnions. You have 2 yolk sacs. But the monochorionic twins have 3 to 5 times higher risk problems than the dichorionic twins. Almost all monochorionic placentas have some type of intertwin vascular connections, which can complicate the pregnancy. It's just how do they share equally or not? So findings that we see with the monochorionic diamniotic twins is the single placenta, same gender, a thin intervening membrane, because now all we have is 2 amnions. We only have 2 layers. There's a higher incidence of eccentric or velamentous cord inserts. And it's very important when you're looking at monochorionic twins of people that'll come along and they'll say, oh, well, this is that baby's fluid and the other baby's was over there, that you really have to turn on the color or turn up your gains to see that membrane because sometimes it's really close to the baby, almost kind of saran wrapped around the baby. So you need to make sure, look at the extremities. If you look around the head and the torso, you may not see it. You've got cord floating there and you think from the cord on up, that's that baby's fluid when it's not. So spend the extra time to make sure that you are seeing the membrane. So you can see this baby's got, this is baby A's fluid all over here. B's is just here. So you want to include some of the other baby's fluid in this baby's measurement. And then we look at bladder and stomach. So some of the complications that we can get is discordant growth because of the unequal placenta sharing. There may be anomalies in one baby. Twin-to-twin transfusion syndrome is another complication because you have these vascular anastomoses where you actually have one baby pumping some of its blood over to the other baby. So one baby has very low fluid, and the other one has too much volume, too much blood. So it's trying to get rid of some of this, so it ends up with polyhydramnios. You have asymmetric fluid distribution and growth. And just looking at this. So this is baby A, this is baby B. Just from looking at this, you can see the size difference between these two. So one is cephalic, baby A is cephalic, baby B is breech. But look at these abdomens. Just by looking at that, you can see that those babies are discordant. So then the next thing we look at is what do the bladders, what do the stomachs look like? So out of your monochorionic diamniotic twins, 10 to 15% of these pregnancies are going to develop twin-to-twin. Development of twin-to-twin is associated with significant morbidity, mortality. The earlier the onset of the twin-to-twin, the higher the mortality rate. So we know if we don't do something with these babies and they're already showing twin to twin at 16 to 18 weeks, one or both of these babies are going to die. So they used to do laparotomies where they actually open up the whole uterus. Mom would have a big incision. They would pull the uterus out, and then they would try to ablate some of those vessels. Now everything's done with the laparoscope and with the laser. So I mean, it's much better now. Now they come out with just 2 little Band-Aids. So staging for twin to twins based on our ultrasound findings. So it's very important that you're very meticulous about what you're looking at, how you're documenting. We want to look at the fluid, the biometry, the fetal bladder and stomach size, looking at the Doppler evaluation, and then cardiac evaluation. Quintero staging is the most common one. We're actually using a combination between Quintero and Cincinnati's, but stage 1 is just oligohydramnios in the donor twin. That's the one that's pumping some of its blood over to the bigger baby. Polyhydramnios in the recipient. Stage 2, you have absent bladder in the donor. Stage 3, abnormal Dopplers. Stage 4, fetal hydrops in one or both of the babies. It's more common in the recipient because it has this volume overload. And then stage 5 is death of one of the twins. The Cincinnati staging is looking more at the amniotic fluid discrepancy. We're using the deepest vertical pockets, discrepancy in the size of the umbilical cords, and then more the cardiac dysfunction. So we'll probably eventually come out with our own scoring system. The cardiac dysfunction really has been helping a lot with our recipient twins, trying to figure out when we want to intervene. One of the things that I've learned since I've been at Texas Children's Hospital is even when you see this and you know that it's going to end up having to have the surgery done, they're waiting until there's enough fluid in there so it's actually thinning the placental mass out, because they want to go in there, they want it as thin as possible because they're looking at the surface vessels on the placenta and they're going to ablate them. So they want to have that polyhydramnios in there. Alrighty, and then looking at the discordance greater than 20%. So we're using a combination of the two. We have 3 fetal surgeons. Dr. Belford is from South Africa, and then Dr. Ruano is from Brazil. And they're a wonderful group. Dr. Shami's from Iran, and it's amazing, these 3 men that come together and how they work on these babies. It's just amazing. So when we talk about the staging, the Doppler is very, very important. So I wanted to just make sure that we went over what the normal flow patterns are and what's abnormal and how we're looking at this. So normal flow in the umbilical artery should have good flow on diastole. It should be low resistance, because that's where the baby's pumping the blood from its body back to the placenta. This is when the artery is having the less oxygenated blood, pumping it from the body back to the placenta. So there should be low resistance. So one of the first signs that we'll see is increased resistance to blood flow. So we'll have an increase in the systolic diastolic ratio. So now we see that in diastole, this is coming closer to that baseline. As we progress, as there's more resistance in the placenta, more resistance to the blood flow, then we can get absent and diastolic flow, and then reverse. When we get reverse and diastolic flow, this baby's in real trouble. So they're usually going to be admitted, and we're going to try to see if we can do an intervention, or if the baby's over 26 weeks, we give steroids, and if we need to, we end up delivering. So it's always, on a day-to-day basis, what are the Dopplers doing? What are the fluid? What do we need to do to try to salvage this pregnancy? Anytime you have absent or reverse end diastolic flow, remember to check the umbilical vein. Normally, you should have good, steady flow in the umbilical vein. And also with the umbilical arteries, there's 2 arteries, so make sure you look at both arteries. If one is abnormal, check the other one. Sometimes the other one has a little bit better flow, and that changes. So you're taking an average of the measurements in the 2 arteries. So make sure you look at both arteries. And then when you get pulsatility in the vein, that baby is in real trouble. So you can see how we have reverse end diastolic flow on the umbilical artery, and then the little pulsations, scalloping of the umbilical vein. One of the other things we'll look at is the ductus venosus. A lot of people have a hard time getting this. You'll see I've purposefully turned up my color gains, decreased the PRF so that I can have a little aliasing here, because if you're looking at the umbilical vein, that's going to be the area of the ductus venosus. So just turn up your gains. It's not pretty color-wise, but it's telling you exactly where to put your gate for your spectral analysis. So you can do it either transversely. This is what the normal ductus looks like. We want to see good flow. Or you can do it sagittally, so umbilical vein coming in, and again, look at the air turbulent flow. It's telling you, hey, put your gate right here. So that kind of demystifies how to get the ductus. And we're doing these ductuses starting at about 16, 18 weeks. So you can get them, it's just learning the technique to do them. All right, again, normal ductal flow, absent, so just like you do with the umbilical artery, absent flow, and then reverse. And then the MCA Doppler. This is if the baby is compromised, the fetus is going to automatically shunt more blood to the brain to keep the brain going. It's helpful to assess for blood redistribution and growth delay, for fetal anemia, and then blood redistribution when you have multiple gestations. So what we want to do is we want to magnify up. We want to look right at the circle of Willis. We want to have that mid-cerebral artery as perpendicular or parallel to our flow as possible. We want to put your gate within 2 to 3 millimeters of the mid-cerebral artery coming off of the circle of Willis. And then we want the parallel flow, and if you're going to use the angle correct, it should be less than 15, our group. It has to be less than 10. They try to get it as close to 0 as possible. And then you're going to be doing an average of 3. You want to do at least 3 of these, and then you're taking an average. This is a normal mid-cerebral flow. You should have nice peak, and it should come down almost to baseline. Now this is increased flow. This almost looks like a uterine. You should not have this much flow in diastole. That's letting you know that that baby is shunting blood up to the brain. It's in trouble. Okay, this is a twin-to-twin prior to laser ablation. Here's baby A. This is baby B. Did everybody see where the membrane was at? That one little area there. Do you see how difficult it is sometimes to see these membranes? Because these kids can kind of be like saran wrapped over to the side when they have no fluid. So turn your gains up, put on the different color filters. I think that blue really helps to highlight the membrane. Change your angle, roll mom on her side. You need to identify that membrane. Don't just go, oh yeah, that looks like it. It's not. Put on your color, make sure that you're not calling cord part of the membrane. I mean, that kid is just saran wrapped over to the side. And then when you roll them to the side too, I mean, babies with gravity, if there's normal fluid, babies should float down a little bit. Well, if it's still stuck up anteriorly, well, you know that kid has no fluid. It can't move away. But yeah, right there, that's the membrane. So she proceeded on. You can see with the 3D. Look at that membrane. I mean, from the head, I mean, then the membrane's just stuck together. And sometimes they will get fooled because they think that, oh, look how thick that membrane is, so it's got to be dichorionic. Well, you can't just look at the membrane, because what happens is you can have 2 parts of the membranes together, and now it looks thicker, and what it is 2 parts of the membrane together. Or sometimes you get what's called the bell clacker, where you have the membrane folded on itself around the baby's abdomen, head, legs, whatever, and so it's moving back and forth like this, just like the little clanger inside of a bell, but it's folded amnion. It's not a thick membrane, so don't get fooled by that. So this is courtesy of Dr. Ruano. It kind of shows what happens with our twins. So we can see this baby is going to be our recipient. This one is our donor. So the membrane kind of comes over here and it's pushing that baby over there. You can see how this baby is getting bigger. Look how the bladder's getting bigger, and that one's getting smaller. And this kid is just kind of saran wrapped over there to the side. So now you have the membrane pushed right against that baby. And what they want to do is they want to come in and they want to map out where the vessels are. And it used to be they would do, just a select few of the vessels, and then they were having recurrence of the twin-to-twin. So right now what they're doing is they're zapping the vessels, and then they're going back and they're creating an equator. They're drawing a line that's trying to separate, trying to give those babies 2 separate circulations. So they'll zap the main vessels, the big vessels. So this is venous to artery, venous to arterial. So you can see these little lines. We'll do this one too, venous to arterial. And he's going to come back and zap this big one too. We used to leave those alone, but then we were having a recurrence of the twin-to-twin. And now they're going to come back, and it's like connecting the dots. So trying to make an equator between those babies. trying to separate that circulation. This is when they first start. We're looking at the vessels. Here's the bigger baby, that's baby A. Coming back in. There's the smaller baby. And see, there's the amnion being pushed right against that baby. That baby's kind of pushed way over to the side. And a lot of times when we're doing these children, and this is the bigger baby now. A lot of times they'll go and they'll look at the hands because, especially with the smaller baby, because it's so hard for us to see because there's no fluid. Take away our fluid, it's hard to see. So they'll go and they'll try to look at whatever anatomy that we couldn't see on the ultrasound. They'll try to look at it while they're in there with the scope. Okay, let me play the other one too while we're in here. So now this is right before they've mapped everything out. Now they're going to go in there and they're going to ablate it. So there's the laser. And really, it's just, it's hunting and searching. You're going through, you're trying to see these vessels, you're trying to zap the biggest ones. And then going back and making that equator. So our job during that time is to look at, if there's the poly, then we're going to take some of the fluid out. And then just checking the heart rates while they're doing this. So there'll be times where they're running the laser ablation, and then other times where we're stopping so that we can look at the heart rates. We are monitoring those every 15 to 20 minutes. We stop and look at everything. All right, so this is after the ablation now. Now you can see how that membrane's kind of floating around in there now? So this is 24 hours after the ablation. And you can see these little flecks in here, old blood and stuff from, after we're doing the ablation, you'll have old hemorrhage that's floating around in the fluid. But now at least you can see the membrane floating around the baby. We usually will keep them 48 hours, and then we send them back to their doc, and we give them a little booklet that they're going to go ahead and they're going to, every time they go in, they're going to measure the fluid, the Dopplers, and we follow them that way. And if they have any problems, then they come back to us. But this baby was so happy to be able to move around. You started to see fluid in the stomach, you started to see fluid in the bladder, and then, nice fluid coming around the baby, giving that baby some room. And then the Dopplers went back to normal. All right, monochorionic, monoamniotic. So ultrasound findings of complication, there's no intertwined membrane. It's a single placental mass. They're at a high risk for cord entanglement. So look for cord insertions that are very close to each other. And if they divide really, really late, then you can have conjoined twins. So look at this cord. Look at the twist, even a true knot in there. So these babies, we rarely will let them go past 31, 32 weeks. Usually by 30 weeks, we admit them. If it looks like they're getting into trouble, then we just go ahead and have the steroids on board and get the lungs as mature as possible and deliver, because they are at a very high risk for cord accident. And this is another baby. Look at this cord. Okay, now our very last babies that we'll look at. So very late division. Did everybody see the back of the head? Head. Looks like they're not even separate there. Look at the thickening here. So some small cystic hygromas. Now a transverse of the chest. So we had one torso, 2 legs, 2 arms. Look at that heart. This is posterior, anterior, left, right. Well, what can we say about the heart? Looks kind of bulky there, and it's kind of midline, huh? What do we say about cardiac access? That's your first sign that something's going on, right? Looking at the heads. Did we say 1 torso, 2 arms, 2 legs, 2 heads? So these are conjoined twins. And look at the hearts. It's always nice when somebody writes up here, right apex, left apex, huh? So you can see there are 2 ventricles here, 2 ventricles there, and when it comes to the crux of the heart, the center of the heart, then they're joined. So twins are the ones that are going to give you problems. They have multiple things that can happen, all depending upon when they divide, if they divide, how much they share, and if they share equally. And these are the babies. And what was interesting, there was more flow on the left side than on the right, so the left side of the body was a little bit larger, was measuring on target, and the right side of the body was measuring a little bit smaller. So this is just the 3D. So you can see the one spine, and you can see how it divides off on the two calvarii. And then the MRI. You can see how it splits off right here. All right, one more twin, our last case. So the other baby looked completely normal. This is the upper twin. We just referred in for abnormal second twin. What do we see? Well, there's a cystic structure. There it looks like the chest, part of spine. Look at all this tissue edema. Measuring the length, there's the spine from the torso to the area of the head. I don't see a calvarium. Does anybody else? The other thing we notice is when we put color on, this is the umbilical artery, so this blood flow should be going out, and it's coming back towards this other baby. Now, transverse of the area of the head. Again, this big cystic area, and then all this tissue edema. And this is the transverse of the abdomen, looking at the abdomen. Look at all this edema. We had a 3-vessel cord on baby A, 2-vessel cord on baby B. So this is a TRAP sequence. It's twin reverse arterial perfusion. It's an acardiac twin. So you don't have any head or upper arms usually because there's no heart to pump blood up. So what you have is the torso and the legs, and usually those can look pretty normal, or you can have just like this globular area with just some basic spine and torso. But they don't have a good head. If they do, it's usually pretty small, and they usually have abnormal upper arms. It's untreated pump twin, 35 to 75% mortality if we don't do something. Because this is like a big AV shunt. This other baby, the normal baby, is pumping its blood over to this other baby. This area, this other amorphic fetus becomes bigger. It's harder and harder on the normal twin. So you have artery-artery anastomosis. Acardiac twin is perfused by the deoxygenated blood from the pump twin. The pump twin has high risk for hydrops, and we treat this with an intrafetal RFA, radiofrequency ablation, where you go in there and you ablate those vessels. So if you can diagnose this, and and the fetal surgeon, they'll come in there, they're standing there when you're scanning, trying to map out where the vessels are. So when they go in there, they already have a plan as to what they're going to do.